The report prevalence of general population varies from 5 to 66% of recurrent aphthous stomatitis. Different subgroups in the general population, of patients appear to have different causes for the occurrence of aphtha. This factor suggests a common disease process. You ready? ¿Nos vamos?
Pero es a las 8:30, son las 8, y van a ser las 8 apenas.
Ya, tenemos que ir por el carro. Vengo. Bueno, 5 minutos. 5 minutos.
A las 8:15 que salgamos, 8:20 está bien, porque no sabemos. Yo nunca he hecho esto, no sé si me lo dan a las 8:30 o a las 8:45, dice entre 8:30 y 9.
Okay. Although no single triggering agent is responsible, the mucosal destruction appears to represent a T cell mediated immunologic reaction with production of tumor necrosis factor alpha. This factor is a major inflammatory cytokine that assists in the ultimate targeting of the surface epithelium for destruction by cytotoxic T cells, CD8 plus. Evidence of the destruction of the old mucosa mediated by this lymphocyte is strong, but the initiating causes are elusive and most likely highly variable. The following all have been reported to be responsible in certain subgroups of patients: allergies, genetic predisposition, hematologic abnormalities, hormonal influences, immunologic factors, infectious agents, nutritional deficiencies, smoking cessation, stress, trauma. Investigators have theorized that aphthous ulcerations develop from an immunologic reaction to an oral antigen. This reaction may arise due to presence of a highly antigenic reagent. Okay. A decrease in the mucosal barrier that previously masked the antigen or immunodysregulation resulting in an abnormal response to normally present antigen. All previous described triggers can be grouped into one of those three categories. One, okay, an antigenic stimulus, okay. So, epithelial pathology, pathologies occurring in the epithelium. Traumatic ulceration or traumatic granuloma. So when there's an ulceration, there's an exposure of the connective tissue because there is no epithelium. So ulceration means exposure of connective tissue. Traumatic granuloma versus pyogenic granuloma. Traumatic granuloma will start as an ulcer, and a pyogenic granuloma will start as a granuloma. A traumatic ulceration in granuloma due to acute or chronic injuries to the oral mucosa. Several specific subtypes are noted. Eosinophilic ulceration, eosinophilic so eosinophilic ulceration, not common in the oral mucosa. Their presence lets you know something is wrong. Or traumatic ulcerative granuloma with stromal eosinophilia, not associated with trauma, and histologically shows sheets of large atypical cells. So candidiasis, infections with the yeast-like fungal organism Candida albicans, is termed candidiasis. An older name for this is moniliasis. The use of this term should be discouraged because it is okay. Candidiasis is by far the most common oral fungal infections in humans and has a variety of clinical manifestations, making the diagnosis difficult at times. Albicans can may be a component of the normal oral flora, microflora, with as many as 30 to 50% of the people simply carrying the organism in their mouths without clinical evidence of infection. This rate of carriage has been shown to increase with age. 60% of ventilated patients older than 60 years who have no sign of oral mucosal lesions. At least 3 general factors may determine whether clinical evidence of infection exists. The immune status of the host, oral mucosal environment, strain of Candida. In the past, candidiasis was considered to be only an opportunistic infection affecting individuals who were debilitated by another disease. Certainly, such patients make a big part of them. However, now clinicians recognize that oral candidiasis may develop in people who are otherwise healthy as a result of the complex host and organism interaction. Candidal infection may range from mild superficial mucosal involvement seen in the most patients to fatal disseminated disease in several immunocompromised patients, severely immunocompromised patients. This chapter focuses on these clinical presentations of candidiasis. So, clinical forms of candidiasis: pseudomembranous, erythematous, central papillary atrophy, chronic multifocal, angular cheilitis, denture stomatitis, hyperplastic, mucocutaneous, and endocrine candidiasis. Now, pseudomembranous or thrush is the best recognized form. Okay, um, it looks like curdled milk. Curdled milk on the oral mucosa. The white plaques are accompanied by are composed of tangled masses of hive yeasts, desquamated epithelial cells, and debris. Scraping them with a tongue blade or rubbing them with a dry gauze sponge can remove these plaques. The underlying mucosa may appear normal or erythematous. If bleeding occurs, the mucosa has probably also been affected by another process, such as erosive lichen planus or cancer chemotherapy. Pseudomembranous candidiasis may be initiated by exposure of the patient to broad-spectrum antibiotics, thus eliminating the competing bacteria, or by impairment of the patient's immune system. The immune dysfunctions in leukemic patients of those infected with HIV are often associated with pseudomembranous candidiasis. Infants may also be affected because of underdeveloped immune system. Mild, consisting, the symptoms are relatively mild, consisting of a burning sensation of the oral mucosa or an unpleasant taste of the mouth. So now erythematous candidiasis. In contrast to the pseudomembranous form, patients with erythematous candidiasis either do not show white flecks or a white component is not prominent, the prominent feature. Erythematous candidiasis is undoubtedly more common than pseudomembranous candidiasis, although it is more overlooked clinically. Several clinical presentations may be seen: acute atrophic candidiasis or antibiotic sore mouth. Typically follows a course of broad-spectrum antibiotic therapy. Patients often complain that their mouth feels as if a hot beverage had scalded it. This burning sensation is usually accompanied by diffuse loss of filiform papilla in the dorsum of the tongue, resulting in reddened, bald appearance of the tongue. Burning mouth syndrome frequently manifests with a scalded sensation of the tongue. However, The tongue appears normal in the condition. Patients who suffer from xerostomia for any reason have an increased prevalence of erythematous candidiasis that is commonly symptomatic as well. Other forms of erythematous candidiasis are usually symptomatic and chronic, including in this category is the central papillary atrophy of the tongue, or medium rhombosis glossitis. In the past, this was thought to be a developmental defect of the tongue. So theoretically, the prevalence of central papillary atrophy in children should be identical to that seen in adults. However, in one study, more than 10,000 children were examined, not a single lesion was detected. Other investigators have noted that a consistent relationship between the lesion of Candida and similar lesions have been induced experimentally on the dorsal tongues of rats. Clinically, central papillary atrophy appears as a well-demarcated erythematous zone that affects the midline, posterior dorsal tongue, and often is asymptomatic. The erythema is due in part to the loss of the filiform papilla in the area. The lesion is usually symmetrical, and its surface may range from smooth to lobulated. So patients with central papillary atrophy may also exhibit signs of oral mucosa candida infection at other sites. This presentation of erythematous candidiasis has been termed chronic multifocal candidiasis. In addition to the dorsal tongue, the sites that show involvement include the junction of the hand, hard and soft tissue, and the angles of the mouth. The palatal lesions appear as an erythematous area that, when the tongue is at rest, contacts the dorsal tongue lesion, resulting in what is called a kissing lesion because of the intimate proximity of the involved areas. The involvement of the angles of the mouth, which is angular cheilitis, is characterized by erythema, fissuring, or scaling. Sometimes this condition is seen in a component of chronic multifocal candidiasis, but it often occurs alone. Typically, older person with reduced vertical dimension of occlusion and accentuated folds at the corners of the mouth. Saliva tends to pool in these areas, keeping them moist and thus favoring a yeast infection. Patients often indicate that the severity of the lesion waxes and wanes. Microbiologic studies have indicated that 20% of these cases are caused by Candida albicans alone. 60% due to combined with albicans and aureus, and 20% only aureus. Infrequently, the infection more excessively involves the perioral skin, usually secondary to actions that keep the skin moist, like chronic lip licking, thumb sucking, chronic use of petrolatum-based salts, creating a clinical pattern known as chelocandidiasis. Other causes of exfoliative cheilitis often must be considered in the differential diagnosis.